Hello everyone. So this is, I guess technically part one, if you want to call it that. I'm going to review the chapter 7 for our case formulation class next week for Psych 610. So I do have a beach scene for you. Here's a beach scene that might, I don't know if that triggers anything in any of you, but my generation, that could be a calm scene, but it's an anxiety-provoking scene because of what's going to happen uh, next. So, anyway, so chapter 7, I have some issues with chapter 7, but and they start off pretty well. So case formulation, case conceptualization, all the same thing. You'll have some examples in the article readings that are related to, that are part of the readings for this class next week. And you're going to notice a big difference between this chapter and that. So in this chapter, our remnants, or you see the counseling model that's different than the cognitive behavioral uh, approach, or really a clinical psychology approach, is going to be different. And I mean, you'll be mostly working with people who get counseling degrees. So the stuff that I present you, I think that the other faculty present you, Erica and Shannon in particular, is really coming from a clinical psychology place. To some degree, CBT also. Anyway, so most models of case conceptualization involve three components. It organizes a broad range of client information into a small number of categories, a concise understanding of the client. Okay, it depends on your model in your head of what that's going to be, how that's going to look, what you're going to focus on. The plan facilitates the process, diagnosis and treatment. Okay, so that's not a big deal. Case conceptualization skills. So here's where they mention theoretical bases, and that's something I'm going to push with you. And some of you, most of you, all of you may not take to it, because you're going to find out that if you stick with a master's, you don't really have to follow a lot of what I'm saying. And we'll talk about that. So counselors work from theoretical orientations. Okay, good. I disagree that they are broadly classified as affective, behavioral, cognitive, or systemic. All right. Behavioral, cognitive, systemic, and other. But the affective thing, so we're going to get into some trouble. Hybrid model for sure. I have a behavioral systems model. So I blend behaviorism with family systems theory. They're not incompatible at all. They're theoretically a little bit different, so, but they're not incompatible in my mind. So, so worldview, diagnostic acuity. So how good are you at picking up diagnoses? This is old school counseling, because originally counselors could not treat people who had DSM-5 diagnoses, or DSM whatever it was at the time, all right? But counselors have become just like clinical psychologists. And the licensing board, you'll see a remnant of this, is that you can get licensed as a counselor, but you can't, but there's a certain things you have to have in school for you to be able to treat DSM-5 diagnoses. So you have to have practica, an internship, and then LPCA work. But you have to have something while you're in school that clearly is treatment of DSM-5 diagnoses, which is why your next 3 practica, or really it's your next 1.5 practica, your 150 hours of practica, have to be with clients with DSM-5 diagnoses. But you can get a license if you don't have such practica. You just can't treat people who have DSM-5 diagnoses, or you can't treat the diagnoses if you treat them. So that's pretty old school, but that's still in there. I don't know of anybody who gets that version of the license, but that's a remnant of the old difference between counseling and clinical psychology. All right, therapeutic goals. Solutions are obvious component, appropriate to the level of the problem, time orientation, what are the time factors, treatment strategies. We can talk about that. Client characteristics. They work against as well as facilitate. You have to assess the client's potential for cooperative participation in counseling. Yes, except if they're not going to be, another view of that is from the stages of change view of motivational interviewing approaches. You'll take anybody, you're just considering where they are in their ability to participate in counseling, in the kind of counseling you think they need. And that's a slightly different model of that, and that's a little bit old school there. I don't know if they mention motivational interviewing in here. I have to double check that. Theory and case conceptualization. So this is important. I'm not going to read the whole chapter 2, but just a couple of points I want to make sure I phrased correctly. Counseling theory attempts to provide explanations about why people live their lives in productive and sometimes unproductive ways. Okay, good. 2, how people can change their lives. So this first statement, all right, good. That's good case conceptualization, case formulation. It's part of your thinking, and determining what you're going to do is you're understanding why they're like they are, behaving, feeling, speaking the way they are. Okay? It says theory can be used as a counselor by the counselor as either foreground or background. No. When you go in to see a client, you have to have a model in your head. You have to have a model of how human beings work and why they have problems. Because if you don't, and you can be what's called an eclectic therapist, all right? But if you don't, then one of the disadvantages is when you have a model, you see things a certain way, behavioral. So you're looking for certain skills they have, don't have, past conditioning experiences, and that's a technical terms for how they grew up, what they learned in their families about feelings and expressing feelings. Think about the cases in the readings. It could be quite rich, your behavioral interpretation of those things. But if you start working with a client and it's not working, you don't assume that the behavioral model isn't working with a client. You think, I must be missing something in my conceptualization of this case in this model. It's like working on a car engine. If you have trouble, if it's not running, and you fix something and it doesn't work, you don't say, well, maybe it's a different engine. Right? You still conceptualize it as a combustion engine, and with certain parts and ways of working. It can be limiting in that maybe a behavioral approach isn't good for a client. But I prefer to train my clinical students to have a model or a blend of models. All right, it's not like your blend, like you try this model for this client, my other model for a different client. No, it's a blend. It's a smooth blend. It's like a smoothie when you go in with that client. So, what they term cognitive consistency, and that's like the light version of case conceptualization. Yeah, that's when they use theory as a background. Anyway, so that's, I'm not sure that this is going to be that important to you, but I hope you start to understand that whether you feel it's important, that you think it's important, because it is important. And as you start to understand this and see clients, it will make more sense. The worldview section is very good. And as you can see, a lot of this stuff now, you're integrating stuff from the other chapters. All right, so none of this should be really new. Worldview stuff, just how it applies to case conceptualization. Culturally, a little explanation about Afrocentric or African worldview is holistic, emotionally vital, interdependent with others. That's important to people. Beyond what Eurocentric culture has. Oral tradition, orientation towards collective survival, role of the elderly, right? So elderly are respected. They can be the head of the family. They're seen as elders, right? We don't really have elders in our society, I don't think. True elders were, if you're an elder, if you're elderly, you're an elder. That's not true in the United States. In some cultures, if you're elderly, you're an elder. Someone with wisdom. All right, so some discussion of that. All right, identity, talk about Asian interdependence, and some other values there. So it's important to keep that stuff in mind when you're trying to understanding why the client is the way they are. And so your treatment is going to also be related to that. But your treatment is going to be related to your case conceptualization, which includes this. Right. So conceptualizing current problems. This is where we start to get into a little trouble. He starts to break things down into like affective, seeing the client as affective problems, cognitive problems, family problems, social problems. In my model, in behavioral model, cognitive model, it doesn't matter what you're feeling, right? It matters in terms of presenting a complaint, but it has nothing to do with you conceptualizing where those feelings are coming from and what they're due to. Here, they're pushing this little model of, you can take an affective approach and deal with treatments for their feelings that are feelings targeted. And that's different than, say, a cognitive therapy is going to go after their emotions, which will change their feelings. A social intervention, a social skills intervention can change people's feelings. The best treatment for anxiety might be a social skills treatment. Anxiety is going to go away when they feel comfortable and with how they engage in social situations, right? If they feel skilled, the emotions go away. So it's this chicken and egg stuff here, right? Is it the chicken or the egg? And they seem to push all that a little bit. I get a little trouble with that. And they do give some explanations about it, but yeah. So diagnosis and case conceptualization, you're going to be pushed to give diagnoses, but a diagnosis is not a case conceptualization. Here, they look at it as like, well, you got to make sure your client doesn't have, you got to identify psychopathology if it's there, or rule it out if it's not. Again, it's a little bit of a counseling model there. You're just going to deal with people no matter what the problem is. Now, what they're talking about pathology, you do want to, the one thing I'd agree with is you want to see if you want to pick up if somebody's got psychosis, because that's a whole different story. And that might be an exception to some of the things I'm saying. Right? So when they say rule out psychopathology, I think they may rule out things like psychosis, basically. But psychopathology can be anything. DSM-5 wise. All right, so issues about time. Therapy is not endless. Some therapies are X number of sessions, right? If you're going to use a manual for some things. But considering time, what's good for the client, what's good for the treatment, how much time should I devote to building rapport? It's a whole new world with insurance companies. At some point, you're not gonna get paid for a whole lot of sessions on just rapport building someday. So, so goals and treatment planning. All right, so there's some technical stuff in there about goals, but I like the Cormier, Nurius, and Osborne 2009 little section here on page 118. 6 guiding principles in preparation of treatment plans. This stuff all relates to what we do with Florence Family Support Center too. It doesn't have to be focused on for what we do. I think a lot of stuff applies. It doesn't have to be focused on a mental health symptom or symptoms. All right, make sure your plan is culturally as well as clinically literate. In other words, you know your stuff from training about what actually is done. It's going to be relevant. Reflect the values and worldviews of the client's cultural identity, not your own. So you're not going to give an Asian client, just start off with hitting them with social skills about how to be assertive with their parents. You have to work with the client as to what they feel comfortable with and how it might be modified with either, suppose they're dealing with an elder, right, where there's clearly elders doing something with them that's not it's not healthy, I guess, in terms of could be anything in terms of criticism or something. And you want to teach the client to talk. You have to be informed about what is acceptable for a younger person to say to an older person in their culture. You don't have to buy it if it's abusive. I mean, I believe that. But clearly you're going to take a little extra care to understand what that means to the client in terms of what they're willing to do, how they're going to do it. Would they bring in another person? There might be some ways that are culturally sensitive for getting messages to somebody that in our individualistic culture would be more okay, right? Social systems, a lot of the stuff, what I thought of when I looked at this section was you want to think of short-term solutions and maybe long-term solutions. And that's what we do at Florence Family Support Center as we start to get at, all right, what do we need to change with this client? Inclusion includes social systems, can include friends, there's level of social support, the type of social support. But we want to impact the system they're in, if possible, or get them to be in a new system. Resources, always big. Family, external support systems, kind of a jargony term. I hate that, but you're talking about supportive friends, families, churches, organizations, helpline stuff. I mean, there must be tons of all kinds of support, online support groups, an actual support group. There's not a lot in Florence. We've actually investigated this for different clients over the years. Like we were looking for a grief group for somebody once. That's a support group. It's hard to find. I forget the outcome of all that. It wasn't easy, and I'm not even sure there was one in the end. But you'd think like McLeod would have one for families whose parents die or family member dies. All right, health and recovery, spirituality, acculturation, language dominance, preference, also worldview, culture stuff. All right, time perspective of the client. I think they raised that earlier in that, some cultures, they're not, Americans are very like planning oriented, like future oriented. time, I was thinking of use of the time, and some my interpretation of what they called like Afrocentric African worldview of being. It's more about now, the now, right? How is life now? It's probably, I mean, ideally it's a Buddhist thing too, right? Staying focused, mindfulness is a very now oriented, staying in the now, right? So, um, clients accurate information. So whatever manuals you use, there's often a patient handbook, and there should be. And if there isn't one, you should provide one. Um, it's a little bit of a fault. Clinical psychologists get some wannabe MDs who just say, "Well, this is the treatment," and that's you're going to do MI-oriented, collaborative model. Even if you're not doing MI, the client's totally in good stage of change, and you're still going to explain things to them, consult with them. Well, here are some possibilities. I could do this. We could do this treatment. Let me tell you about it. What do you think? And you want to give them as much information as possible as included in that little section there down, like the 2/3 of the down the chapter. Strategy selection. So there's a lot of discussion here about strategy selection. Now, even the CBT people, I mean, you're going to have options between doing like a systematic desensitization thing, which is a combination of relaxation and exposure treatments, social skills stuff. If you're a straight behavior, if you're cognitive, you could do a cognitive approach, and you could do a little of both. I mean, that's not in my mind, it's a sin, but not in the current world, everybody's CBT. But you could do different things. So you get to pick, but generally you're going to have a few things that you tend to do for that problem. Certainly these agencies, are using things that are well known, and for trauma treatment, like the VA has two main ones that you're supposed to use as a VA clinician, right, that they recommend. I don't think they've mandated it, but there's two empirically validated treatments that they want you to use. Use one or the other. So when you have options, there's some considerations, but it's not like you've got 100 options, because there's typically things you would typically do for certain kinds of problems. Although what you do and how you do that technique, what you focus on, depends on your model. And certainly what you're going after is going to be, well, it's going to be incorporated in a lot of the treatments anyway. So we'll talk about that a little more, but I just feel like that section is about I don't know, like you've got a whole set of tools, and you tend to have a few main ones, is what it is. But within the main one, and certainly what you go after as part of your case, excuse me, is going to differ among models, and then sort of how you implement the treatment may be different. All right, affective interventions. Again, these are all nice definitions of different types of interventions, but you can use any one of these for any type of problem, affective problem. And the book keeps going back to suggesting, well, maybe it wouldn't be a bad idea to use affective interventions for affective problems. I don't want to misrepresent them on that, but why it's even a point of discussion, it's model dependent. It's dependent on your model, and they clearly are addressing, and they needed a book to deal with people who are not maybe going to be model specific. So table 7.1 is a nice little description of not sure I agree with even their breakdown of the categories, but that affective category bugs me. But some explanations there. We're going to cover most of those at different intensities or amount of time next semester, right? Certainly I encourage you to look up anything that sounds interesting to you. Transactional therapy was big in the 60s, and is still to this day It's called TA. Sometimes you'll see it referred to as TA, where people have scripts in their head that they learned. Um, kids don't do this, um, or and that their behavior is guided by these scripts, and so you try to change the scripts. Um, and the family systems are very different also. But anyway, so a nice little explanation here of some different models, but breaking them down into the counseling strategies and corresponding manifestations of client problems. Yeah, this is the part I have trouble with. I'm going to let you alone on that. I hope you get what I'm saying at this point. So the case illustration of strategy and interventions for Angela, this little section, I kind of wanted to look at. They actually say what the therapist's background is. And a good idea would be to look for the therapist's model in, because Angela's going to be in the whole book, as to deciding what they do. They must have a blended model. They prefer an affective approach. Again, it drives me crazy. Elements of person-centered theory and existentialism, right? So meaning, that life's meaning, person-centered. This person has got some difference between their ideal self and their real self, and they're far apart, and that's causing problems. Now, I hope that's what they're referring to, the model, because there's a Rogerian conceptualization of why people have problems, as well as a Rogerian treatment. We're just using the Rogerian treatment for all of our therapeutic alliance stuff, right? You'll see hints of it in some of the descriptions, but we're not conceptualizing cases from a Rogerian point of view in terms of the disorder. And that's a whole other thing. That relates more to some of the humanistic stuff. Right, self-actualization, right? The Maslow's hierarchy of needs, all that stuff is actually part of case conceptualization for a Rogerian or humanistic therapist. Okay, so counselors practice about 4 years, several training. Right. So these are the 6 things they're going to look over. 6 facts for establishing a counseling strategy. Counselor's background, how much experience they have. I'm not sure that should really be a factor. Character of the problem, different dimensions to it. Typical responses to her problem. I mean, characters of the goals. She's got 3 main goals. And her characteristics. All right, so a little bit of background here. So defining a counseling strategy, all right, again, you got to synthesize. You've got to come up with a fairly, like a thematic explanation of what's underlying all this stuff for Angela, right? What's the basic theme? And again, you can use some of this for the Angela case. They tie her childhood to how she is more, and that the way they do that is more of a case conceptualization. Something about her relationship with her parents, how they treated her, her role in the family. So she ended up like not being good at taking care of herself and always expecting other people to take care of her, which is a little bit why the divorce is such a huge deal. That little block on page 122, it's descriptive. It doesn't explain. These are descriptive, affective, behavioral. These are all just aspects of the problem. All right. Unresolved feelings from a marriage. Okay. So why does she have self-defeating thoughts? Right? What function does that serve for her? For my model, I'd be like, why is she being like this? Because that's all she really knows how to do. And it works in a terrible way. That's what the term dysfunctional, right? Is it works, but it doesn't work well and causes problems. But she must be getting something from it, right? Or it's helping her avoid some fear. So if we went into my model more, it's not just behavioral Skinner, it's behavioral Pavlov and Pavlov plus Skinner, which is basically negative reinforcement is important when you've had a lot of negative emotions conditioned. And then certain coping strategies make those fears go away. And so what I like is her role in her family of origin. I'm not sure if where they bring that up again, but that to me was a key and a nice part of the case conceptualization. So selecting interventions. So we're getting into the general counseling stuff again. Like I said, it's not like you're gonna carry around or have in your office like this big toolbox. There's 100 things I could do with her. When you have a certain model, there's certain kinds of things you do. You might do systematic desensitization kinds of things. You can do skills training, but you're not going to use every skill in the social skills manual if you're following me. So what you pick out of that is going to be determined by what your case conceptualization is within a behavioral frame and maybe within a systems frame as to what function this person's serving, the way they're acting. You help them act not that way. Maybe the system will change a little bit. You might do some systems related things too. So, of course, anxiety will be experienced somatically, cognitively, affectively, systemically. Usually more than one intervention is also necessary. I would disagree to that in the extent that you would not need more than one technique to get at anxiety. But you'll do a bunch of other things related to it. So your person's going to do homework. They're going to do a lot of things to increase the generalization of their anxiety reduction tasks that they're working on. You're going to find social support. You're going to look at family issues too. But you're not going to do a different treatment for their behavior, their thoughts, and their affective components, what they call depression here. Now, if she's depressed, I don't know. I think usually I like to think that there's one bottom line theme for a person that seems to be affecting how they are coping with life and how they're dealing with people in life and doing things and not doing things that make people happy, and doing things that make people unhappy. Doing the kinds of things that make people unhappy. Not doing the kinds of things that make people happy. But it's common in CBT. You can do cognitive work and some behavioral work. So it's not completely out of the question. All right, strategies for working with children. Remember, there was a similar section in an earlier chapter just about, all right, how is this related to kids? And they're making more of a big deal here about tied to the environment. Of course, people still will take a kid in and treat a kid and do like child therapy with the child. But of course, the kid's behavior and their feelings and their thinking isn't going to be separate from their environment. So, So we go over techniques. We're going to cover some of the child techniques. They'll be mainly CBT oriented things. But we'll talk about a bunch of different approaches. I mean, this Freudian child therapy. Child CBT, some of the other ones, are not really built for kids necessarily. Cognitive therapy is built for kids. There are modifications of it for kids, like 8 years old, 10 years old. And some of the trauma-focused child therapy, which I will have you do the training for. If you're interested in working with kids, probably everybody should do it, but there are cognitive components. So, but really, the emphasis, how you can do that without it impacting and bringing in the environment, addressing the environment, is a little bit beyond me. I wouldn't be able to do it, just treating the kid. I might get a kid who's separated from a family that was abusive, the kid's not going back to the family. But they're going to be with other families. So you really want to train the other families and their caretakers how to deal with the kid. There's some work you can do with the kids also. I guess I'm probably thinking, treating a kid going back to the same family, that's an issue to talk about someday, isn't it? All right, I think I'm going to leave it there, and you have the other readings also. Hope everyone's doing okay at this point, whatever week they are seeing this. We'll talk to you later.